developed? It is not the proper modality to comment. Please answer. The correct answer, it is not the proper modality to comment, as the external and the middle ear development is better evaluated by the CT, yet still normal right external auditory canal and the atretic left side are seen in the MRI. In the same patient, regarding the arrowed structure in the left ear sagittal plane, it is normal cochlear nerve, normal facial nerve, normal inferior vestibular nerve, or it is hypoplastic cochlear nerve. Please answer. Yes, it is hypoplastic cochlear nerve. After reviewing the MRI, this child has right labyrinthine aplasia with normal external auditory canal, left IP1 anomaly with hypoplastic cochlear nerve and external auditory canal atresia. Which ear is candidate for the cochlear implant? Check all that apply. The left ear is candidate for cochlear implant. The left ear is a relative contraindication for cochlear implant. The right ear is an absolute contraindication for the cochlear implant. The left ear is an absolute contraindication for the cochlear implant. Please answer. We discuss this case with our clinician who think it is difficult decision with expected poor response in the left ear and the CSF gusher. So the right answer is the left ear is a relative contraindication for the cochlear implant, and the right ear is of course an absolute contraindication for the implant. My next case, a 10-year-old child patient with left moderately severe and right mild sensory neural hearing loss. Check all that apply. The spine anomaly is irrelevant to the pre-implant imaging. CT shows hypoplastic right internal auditory canal. Usually contrast is not used in the pre-implant imaging protocol. Spine and cerebellopontine angle anomalies form the main features of a well-known syndrome. Please answer. The correct answer is usually contrast is not used in the pre-implant imaging protocol. Sentence A is wrong, as the spine imaging is not part of the pre-implant imaging protocol, but in this child with Chiari 1 malformation may explain part of the presenting symptoms. Sentence B is wrong, as abnormal widening and scalloping of the left internal auditory canal. On the contrary, the right canal is a normal one. And sentence D is wrong, as the shown anomalies form two separate syndromes that may associate. During reporting, we noticed a cord-like abnormality passing around the cochlear promontory, that is arrowed structure. Please check all that apply. It is glomus tympanicum. It is a facial nerve schwannoma arising from the tympanic segment. It is a chorda tympani schwannoma. It is a Jacobson nerve schwannoma. Please answer. It is a Jacobson nerve schwannoma. This nerve is a branch of the glossopharyngeal nerve, enter the tympanic cavity via the inferior tympanic canaliculus and contribute to the tympanic plexus on the cochlear promontory. Some studies suggest that Chiari-1 malformation should be accepted as one of the central nervous system anomaly seen in neurofibromatosis type 1. Neurofibromatosis type 1 is often associated with a wide variety of central nervous system dysplasia. However, the association with Arnold-Chiari type 1 malformation is unusual. In this case, the left sensory neural hearing loss is explained by the vestibular schwannoma extending along the internal auditory canal. We presumed that Chiari-1 malformation is the cause of the right sensory neural hearing loss and possibly contribute to the left side symptoms. During the caudal shift of the brainstem in Chiari-1 malformation, the eighth cranial nerve is compressed upon or over the bony edge of the porus acousticus, in addition to the direct compression of the brainstem nuclei by the cerebellar tonsils. My next case, a 36-year-old female patient with bilateral sudden sensory neural hearing loss following an attack of domestic violence. MRI was done searching for a hematoma compressing the nerve or any type of nerve injury. Please check all that apply. There is no obvious nerve injury, however, cochlear concussion is noted. Pre-existing vascular anomaly is the cause of the current patient's complaint. Pre-existing congenital inner ear anomaly is the cause of the patient's complaint. By history and the current MRI images, it is a case of central cause of hearing loss. Actually, the study is unremarkable and further imaging is needed. Please answer. The correct answer is pre-existing congenital inner anomaly is the cause of the patient's complaint. Sentence A is wrong as there is no cochlear concussion. The cochlea shows normal signal in T1 and T2. Sentence B is wrong and I will discuss this choice later. Sentence D is wrong as no available radiological features of central hearing loss. And sentence E is wrong as variable abnormalities are noted. I report this as a case of bilateral dilated endolymphatic duct and sac anomaly, or what is known enlarged vestibular aqueduct. The clinician was not convincing with my report and he asked for CT, searching for an otic capsule violating fracture, and this is the sagittal oblique view confirms that enlarged vestibular aqueduct. The vestibular aqueduct was considered enlarged when its width at midpoint measures 1.5 millimeter, but with advancement of the CT, now it is considered enlarged when the midpoint exceeds 0.9 millimeter. Enlarged vestibular aqueduct is the most common radiologically detected abnormality in patients undergoing evaluation for sensory neural hearing loss. The typical and dreaded progression of this syndrome is a gradual deterioration of hearing through the childhood into adolescence and early adulthood, with a tendency to suffer sudden drop of hearing, particularly after head trauma. Different theories about hearing loss in enlarged vestibular aqueduct, and the most common suggests that enlarged vestibular aqueduct form an abnormal communication between the subarachnoid space and the fluid chambers of the inner ear, which increased CSF pressure, which damages the hair cells. After reviewing the arrowed structures in the same patient, what makes this choice is incorrect? Do you remember it? Pre-existing vascular anomaly is the cause of the current patient's complaint. Why this choice is incorrect? It is a hematoma around the cochlear promontory. It is a fracture line passing the facial nerve canal. It is a facial nerve schwannoma affecting the tympanic segment. It is a pre-existing vascular anomaly not related to the patient's recent symptoms. Please answer. The correct answer is pre-existing vascular anomaly not related to the patient's recent symptoms. Sentence A is wrong because it is not a hematoma, it is an apparent course of internal carotid artery passing around the cochlear promontory. Sentence B is wrong because it is a duplication of the anterior segment of the tympanic facial nerve canal. Sentence C is wrong because it is persistent stapedial artery as it traverses the floor of the middle cranial fossa to give rise to the middle meningeal artery. It is an accidental discovery of apparent internal carotid artery with persistent stapedial artery, and here is the rest of the images. Absent right-sided foramen spinosum compared to the contralateral normal side. The duplication of the anterior segment of the tympanic facial nerve canal housing the persistent stapedial artery, and there is enlarged inferior tympanic canaliculus transmitting this artery, and here is the string sign which refers to the persistent stapedial artery coursing over the lateral surface of the cochlear promontory. In this case, the subtle radiological abnormality noted in unexpected age in a patient with no past history of hearing loss made the diagnosis challenging. The coexistent vascular anomaly added to the confusion. My next topic is about the obstructed cochlear lumen. In this topic, I want to discuss the patency of the cochlear lumen, the normal composition of the internal fluid, and the intact blood labyrinthine barrier are essential for the normal hearing. Cochlear lumen obstruction could be mechanical or functional in form of alteration of the internal media. The imaging protocol should be tailored according to the clinical scenario. This diagram illustrates my idea. Here is the open chambers of the cochlea transmitting the normal sound waves, and this is an obstructed cochlear lumen by either mechanical obstruction or change of the internal media impedes the sound wave transmission, and this is an obstructed cochlear lumen from external compression by abnormal otic capsule. My next case is a 5-year-old child with recurrent attacks of meningitis complicated by sensory neural hearing loss, referred for pre-operative evaluation for cochlear implant. Please check all that apply. This is normal cochlear development, patent cochlear lumen. Congenital inner ear anomaly is the cause of recurrent meningitis. The study is unremarkable. Please answer. The correct answers are that it is normal cochlear development and patent cochlear lumen. Sentence C is wrong as there is no congenital inner ear malformation, and sentence D is wrong as there is significant abnormality in this study. In the same patient, regarding the MRI, check all that apply. MRI confirms patent cochlear lumen. Enhancing a cochlear lumen is a normal finding in this age group. It is a case of encephalomalacia of the brain with central hearing loss. All the above are false. Please answer. The correct answer, all the above are false. Sentence A is wrong as obstructed cochlear lumen with loss of the fluid signal is obviously seen in MRI. Sentence B is wrong as enhancing a cochlear lumen is always pathological. Sentence C is wrong as the frontal lobe encephalomalacia is not a cause of central hearing loss. The undiagnosed anterior skull base defect with meningocele are the cause of recurrent meningitis. And it is a case of fibrous stage of labyrinthitis. Labyrinthitis is a major cause of hearing loss in different diseases, as meningitis, ototoxic drug, autoimmune disease, and even surgical trauma. Labyrinthitis ossificans is the result of a neglected labyrinthitis. And regardless the triggering cause of labyrinthitis, the cochlear inflammatory process follows the same pathological cascade with corresponding radiological findings. Here is an acute stage of labyrinthitis with normal T2, however, contrast enhanced of the cochlear lumen by the inflammatory debris is the only radiological finding. And this is fibrous stage of labyrinthitis where there is loss of the fluid signal in T2 and there is enhancement of the cochlea. The CT is still normal. And this is the last chronic stage in labyrinthitis ossificans in which ossification of the fibrous matrix obstructs the cochlear lumen. My next case is another 10-year-old child with recurrent meningitis and bilateral profound sensory neural hearing loss. Please check all that apply. The right cochlea is fully developed, however, it has an obstructed lumen. The left cochlea has a patent lumen, however, it is malformed. There is a congenital CSF fistula that causes the recurrent meningitis. The primary cause of the sensory neural hearing loss is the recurrent meningitis. Please answer. The correct answers are the left cochlea has a patent lumen, however, it is malformed. There is a congenital CSF fistula that causes the recurrent meningitis. Sentence A is wrong as the middle and the apical turns of the right cochlea are fused together with defective corresponding modulus and interscalar septum. Sentence D is wrong as the primary cause of the sensory neural hearing loss is the inner ear malformation, but the recurrent meningitis accentuated it. This child has right incomplete partition type 2 and left incomplete partition type 1 anomaly with defective left lamina cerebrosa and congenital CSF fistula correspond or predisposing the patient to the recurrent meningitis that was complicated in this case by labyrinthitis ossificans partially obstructing the right cochlear lumen. This is my next case. A 15-year-old male patient referred for MRI cysternography. The medical report sent by the clinician is shown. Here is the medical report. He told us this past history of head trauma long time ago. This patient has recurrent acute bacterial meningitis and much brain imaging was done. Please for MR cysternography. MR cysternography was done through the different skull base regions, searching for the site of the CSF leak. Check all that apply. There is an anterior skull base defect through the cribriform plate of ethmoid. There is a central skull base CSF through Sternberg's canal, which is a congenital bony defect in the lateral wall of the sphenoid sinus. The CSF leak is through the tegment tympani. There is no CSF leak in the shown images, but there is another clue. Please answer. The correct answer, there is no CSF leak in the shown images, but there is another clue, and here is the clue. Look to the magnified views. This is a case of congenital CSF fistula through a defect at the level of the stapes foot plate, commonly associated with IP1 anomaly detected in this case. Many challenging issues in this case. A misleading history of a remote head trauma and multiple previous brain imaging. Ignored hearing loss in the history, considering it a sequel of meningitis. That is the requested cysternography protocol rather than a dedicated cochlear implant protocol. Meningitis and hearing loss are bidirectional causation. IP1 anomaly is commonly associated with recurrent meningitis due to abnormal otic capsule that is involved in the formation of the stapes foot plate and the annular ligament, resulting in the congenital fistula. The defective lamina cribrosa and the wide communication with the internal auditory canal is another factor. My third topic is what is after cochlear implant. In this topic, I want to discuss the electrode position after the implant, the inner ear trauma, and the difficult cochlear implantation. First, the cochlear implant is formed of external board that is formed of a microphone, a speech processor, and a magnetic headpiece, and the internal board, which is formed of a receiver stimulator and the electrode, which is a core of the system surgically inserted into the cochlea and stimulate the residual cochlear nerve. My next case is a 12-year-old child patient with a history of cochlear implant 5 years ago, presented recently with diminished hearing simultaneously with mouth angle deviation. What is the type of inner ear trauma? Check all that apply. It is a scala vestibuli insertion, scala tympani insertion, scalar translocation, or it is a lateral wall fracture. There is no inner ear trauma. Please answer. The correct answers are scalar translocation, as the electrode translocate from scala tympani to vestibuli, and the lateral wall fracture, as the implant breaks through the cochlear wall to the adjacent structures. Sentence A is wrong as the electrode is inserted in the scala tympani. Sentence B is wrong as scala tympani insertion is not an inner ear trauma, actually it is the proper site for the implant. And sentence E is wrong as an inner ear injury is seen. In the same patient, regarding the injured extracochlear structures shown in these images, check all that apply. There is geniculate fossa injury, tympanic segment of the facial nerve canal, the mastoid segment of the facial nerve canal, the labyrinthine segment of the facial nerve is not affected, and stapedius muscle and tendons are injured. Please answer. The correct answers are the geniculate fossa and the tympanic segments of the facial nerve canals are injured. I want to comment about why the labyrinthine segment of the facial nerve is affected, because I see its abnormal widening of the bony canal and I think it is a chronic neuropathic hypertrophy. This is another patient with in-place cochlear implant with normal facial nerve canal. Electrode migration out of the cochlea accounts for only a minority of revision surgeries. The underlying mechanisms for the electrode migration are poorly understood. It is more common in children with new bone formation and mastoid growth. Head trauma and intracochlear fibrosis or ossification may also lead to an extrusion of the electrode out of the cochlea. Gradual internal migration out of the implant in a non-traumatic case should be considered in the rare and higher risk post-cochlear implant complication. This is one of my patients. Even there is injury of the carotid canal due to migration of the implant. My next case, a post-meningitis sensory neural hearing loss with poor response after implant. Check all that apply. It is a scala vestibuli insertion. Basal turn of the cochlea is obstructed. Complete insertion of the electrode is seen. The implant passes through the round window. Please answer. The correct answers are it is a scala vestibuli insertion and the basal turn of the cochlea is obstructed. Sentence C is wrong as extracochlear electrode are noted, and sentence D is wrong as the implant passes through a cochleostomy. Poor performance of the electrode with incomplete insertion scala vestibuli in a partially obstructed cochlear lumen. Only few electrode contacts are seen within the apical and middle thirds. The surgical technique of the cochlear implant are usually standardized and the regular implant electrode can be inserted in the majority of cases. Special cases, however, such as implantation in patients with anatomical malformation, obliteration of the cochlea, or re-implantation pose a challenge in the cochlear implant. And alternative surgical techniques such as incomplete insertion, implantation into scala vestibuli, or radical cochleostomy must be considered. All these methods are associated with some disadvantage, such as poor performance of the implant, a significantly higher risk of injuring a facial nerve, internal carotid artery, or the modulus. Complete insertion and the number of working electrodes are believed to be the important factor for the satisfactory results. My next case is post-cochlear implant abnormal response during device programming. No sound sensation, however, pain and facial nerve stimulation. After radiological evaluation, check all that apply. This is complete insertion of the implant. Electrode array reaches to the middle turn. Electrode is folded upon itself within the basal turn. Scalar translocation between scala tympani and vestibuli. Please answer. The correct answers are complete insertion of the cochlear implant. Electrode is folded upon itself within the basal turn. There is scalar translocation between tympani and vestibuli. Sentence B is wrong as electrode contacts are seen within the basal turn with empty middle and apical turns. Also complete insertion, the electrode is folded upon itself within the basal turn of the cochlea, resulting in abnormal stimulation during programming. My next case, what is the cause of the failed implant in this patient? Check all that apply. It is obstructed cochlear lumen, otic capsule structural changes, abnormal kink of the electrode array within the cochlear lumen, unsuitable type of the implant. Please answer. The correct answers are it is obstructed cochlear lumen and otic capsule structural changes. Sentence C is wrong as the implant passes to the vestibule with no intracochlear electrode. Sentence D is wrong, and this may or may not be true regarding the unsuitable type of the implant, however not obvious in our CT study. Cochlear lumen obstruction is a common finding at time of cochlear implant in advanced otosclerosis. Otosclerosis may necessitate an altered surgical approach or use of a special type of electrode and may result in incomplete electrode insertion or increase the rate of the facial nerve stimulation. Incomplete or false tract electrode insertion occurs secondary to the abnormal otic capsule in the retrofenestral disease. The proper intracochlear position of the electrode array are crucial for an optimal neural activity. Scala tympani placement is preferred as it has the least imaging effect to the least damaging effect to the intracochlear structures. Alternative scala vestibuli insertion may result in damage of the organ of Corti and other ultrastructures of the cochlea. Scala vestibuli insertion of the cochlear implant with empty scala tympani as in this image, and this is another case with translocation of the implant between scala tympani and vestibuli with fracture of the osseous spiral lamina. This is my research about the different types of the inner ear trauma, and the worst of all is the translocation between scala tympani and vestibuli with fracture of the osseous spiral lamina containing the organ of Corti or organ of hearing. This is a child female patient with history of left explanted cochlear implant after head trauma and right cochlear implant. Started to experience degradation of the implant function 3 years after implantation, itching and ear discharge. Check all that apply. Right ear partially extruded electrode with secondary infection. Right ossicles are eroded and displaced. Diffusion weighted images is recommended to exclude cholesteatoma, and empty left well after explantation is seen. Please answer. The correct answers are right ossicles are eroded and displaced and there is empty left well after explantation. Sentence A is wrong as the implant is completely inserted, and sentence C is wrong. Even with MRI compatible devices, the artifacts around the implant in the same ear will mask the diffusion restriction of cholesteatoma, so diffusion weighted images will not be a practical choice. Right ear cholesteatoma eroding and displacing the ossicles, representing late cochlear implant complication, and here is the left-sided empty well and partially obstructed basal turn of the cochlea after explantation. The development of cholesteatoma in post-implant patient could be the result of a surgical breach of the tympanic membrane and or external auditory canal during the implantation surgery. My last case, the 10-year child-old female patient, Syrian girl, developed bilateral sensory neural hearing loss after missile exploded close to her home. She had left ear cochlear implant and a right mastoidectomy for a cholesteatoma that subsequently developed in the right ear. Unfortunately, the implant was later extruded into the middle ear cavity and the patient was referred for a radiological evaluation before re-implantation. Here is the CT and MRI of the patient, and here is the marked artifact around the implant, which is still within her ear. I cannot see the inner ear structure or the internal auditory canal, and this is the contralateral side, shows residual or recurrent cholesteatoma with diffusion restriction, and the good news is the normal right cochlear nerve. So what are recommendations for post-cochlear implant MRI? An indisputable need for the MRI, agreement among clinicians, radiologists, and the patient, the manufacturer's authorization, a time interval between device implantation and MRI of at least 6 months, removal of the implant's external component, and close-fitting compressive bandage. Pain and magnet displacement are the most frequently described complication. Another problem is the artifact generated by the magnet or the electrode which contains titanium. Image distortion may spread up to 6 cm around the electrode holder in 1.5 Tesla MRI and may extend to 12 cm in 3 Tesla MRI. The radiologist should understand the reasons for the cochlear implant revision surgery. The most common reasons are device failure, flap-associated problems, inner device migration, and post-operative CSF leakage. Thank you.
نشكر الأستاذة الدكتورة توجان طه على هذه المحاضرة والإنتر أكتيف كيسز الدسمة. الحتة دي هي بايونير فيها الحقيقة، ويعني بتشرفنا في كل حتة. هي المتخصصة الحتة بتاعة الكوكلير implantation which is very essential for the assessment before the procedure، ومحتاجة يعني meticulous review بالسي تي والام ار اي. وحقيقه الاستاذه الدكتوره توجان متميزه في النقطه دي وبتعلم دايما الاجيال الجديده، فيعني نامل ان يبقى في ناس اكتر في نفس شطارتها ومهارتها في حته الكوكلير نيرف امبلانتيشن اسسمنت. ولو في اي سؤال من الساده الحاضرين بالنسبة للمحاضرة بتاعة الكوكلير نيرف والمحاضرة بتاعة الفينس ساينس ثرومبوزيس ما خدناش عليهم الأسئلة، فلو في أي حد أسئلة. طيب شكرا جزيلا دكتورة توجان، وبشكر الحضور تاني ومنظمين المؤتمر، و إن شاء الله تبقى